The first topic of our lecture will be periventricular intraventricular hemorrhages, PVIH. Hemorrhages can be identified in 67% of infants born prematurely at 28 to 32 weeks and 80% of infants born between 23 and 24 weeks of gestation. The majority of hemorrhages, about 90%, are identified within 4 days of birth. Changes in perfusion of the delicate cellular structures augmented by the immaturity of the cerebral circulatory system are the main reason of bleeding. Significant stress experienced by a premature infant after birth may cause these vessels to rupture. This picture shows us 4 grades of germinal matrix hemorrhage. You can see normal coronal view through the brain with brain parenchyma, germinal matrix and lateral ventricle. Grade 1. Hemorrhage confined to germinal matrix. There is no intraventricular extension. Grade 2. Include intraventricular extension involving less than 15% of its volume. Grade 3. Intraventricular extension involving more than 50% of its volume, or extension into dilated ventricle. And grade 4 with intraparenchymal extension. In this slide, we can see the different stages shown in the ultrasound images in the coronal and sagittal section. In ultrasound, germinal matrix hemorrhages appear as echogenic regions close to the caudothalamic groove extending along the floor of the frontal horn of the lateral ventricle. Prognosis depends on the extent of hemorrhage and presence of hydrocephalus. Grade 1 and 2 hemorrhages have a good prognosis, whereas grades 3 and 4 have a poor prognosis with a 90% mortality for grade 4. If hydrocephalus is present, cerebrospinal fluid drainage may be necessary. Treatment: antenatal dexamethasone administered to the mother or indomethacin administered to the infant also decrease the incidence, but the mechanism is unknown. And like I said, if hydrocephalus is present, cerebrospinal fluid drainage may be necessary. The next topic will be about esophageal atresia. It's the most common congenital anomaly of the esophagus. It is thought to occur in 1 in 3 to 4,500 live births. Esophageal atresia refers to an absence in the continuity of the esophagus due to an inappropriate division of the primative foregut into the trachea and esophagus. General pathogenics includes teratogenic effects caused by early pregnancy, use of antithyroid drugs like metamizole, carbimazole, and propylthiouracil. Esophageal atresia may be suspected on antenatal ultrasound or in the neonate due to inability to swallow saliva or milk, aspiration during early feedings, or failure to pass a nasogastric tube into the stomach successfully. In this slide, we see 5 types of atresia. Type C is the most common. It occurs in 85% of cases. We can see proximal atresia and distal fistula. The second most common is type A. It occurs in 8% of cases. It's isolated esophageal atresia. The other types are rare. Type A occurs in 4% of cases. with isolated fistula H-type. Type B with proximal fistula and distal atresia. And type D with double fistula and esophageal atresia. If an esophagogastric tube insertion has been attempted, this may show the tube blindly looping and turning back at the apparent thoracic part of the esophagus or heading into trachea and or bronchial tree. It may show a dilated pharyngeal pouch. On the next plain radiograph, we can see the presence of air in the stomach and bowel. In the setting of esophageal atresia implies that there is a distal fistula. There must be a connection between trachea and the digestive tract. Fluoroscopy. Contrast swallow may show contrast blindly ending and pulling in an esophageal stump, and sometimes may show evidence of the tracheoesophageal fistula. On this picture we can see contrast in bronchial tree. Fluoroscopy is particularly useful in demonstrating H-type fistula. Antenatal ultrasound is non-specific but may not show the expected shape and position of the stomach. Esophageal atresia should be suspected if other vectoral anomalies are seen. Polyhydramnios may be present particularly in cases where there is no concurrent fistulation. The fetus may appear growth restricted. The subtypes without tracheoesophageal fistula may be suspected in the context of persistent non-visualization of the fetal stomach. Vectoral is an acronym that describes a non-random constellation of congenital anomalies. It is not a true syndrome. The acronym Vectoral derives from V. Vertebral anomalies like hemivertebrae, congenital scoliosis, caudal regression, or spina bifida. A. Anorectal anomalies like anal atresia. C. Cardiac anomalies, cleft lip. D. Tracheoesophageal fistula or esophageal atresia. R. Renal anomalies. L. Limb anomalies like polydactyly or oligodactyly. At least 3 of the above features are considered necessary for the diagnosis of this condition. Treatment and prognosis. Surgical intervention with a reanastomosis can be attempted post-delivery. Esophageal strictures secondary to surgical correction of esophageal atresia is a common complication after surgical procedure, usually requires further correction. Hirschsprung disease is the most common cause of neonatal colonic obstruction, about 15 to 20%. It's commonly characterized by a short segment of colonic aganglionosis affecting term neonates. It occurs in 1 in 5 to 8,000 live births. We observe a greater proportion among male genders, which reduce with increasing length of involvement. What's more important, it's almost never seen in premature infants. Hirschsprung disease can be anatomically divided into types of according to the length of the aganglionic segment. Short segment disease, about 75%, rectum or rectosigmoid involvement only, 20% long segment extends orally in the colon, and 5% total aganglionosis, entire colon, sometimes involvement of small bowel. What we can say about clinical presentation? The condition typically presents in term neonates with failure to pass meconium in the first 1-2 days after birth, although later presentation is also common. Overall, about 75% of cases present within 6 weeks of birth, and over 90% of cases present within the first 5 years of life. A very small number may present in the adult population. Fluoroscopy is very useful in the diagnosis of Hirschsprung disease. In the present photo, we can see the saw-teeth contractions. Normally, the rectum should be wider than the sigmoid. The image shows us abnormal rectosigmoid index below 1. The affected segment is of small caliber with proximal dilatation. On plain radiograph and ultrasound, findings are primarily those of a bowel obstruction. In protracted cases, marked dilatation can develop, which may progress to enterocolitis and perforation. On this plain radiograph, we can see dilated loops, which is suggestive for obstruction. Surgical treatment is by removal of the affected portion of the colon. Where this is successful, the prognosis is good. However, in 3 to 4 of cases, colonic perforation complicates presentation. Mortality rates can be as high as 30% due to enterocolitis. Anal atresia or imperforate anus. It is a spectrum of anorectal abnormalities ranging from a membranosus separation to complete absence of the anus. Anal atresia is a part of the vactal malformation. The diagnosis of anal atresia is usually clinically straightforward by inspection and digital palpations. It's thought to occur in 1 to 5,000 live births. We can divide it into 2 categories: high, supraelevator, or low, infraelevator, depending on the location of the atretic portion. What kind of signs we can see on plain radiograph? The plain radiograph may show multiple dilated bowel loops, here, and absence of rectal gas. Also, we can see air within urinary bladder, suggests high type, and calcified meconium in the bowel loops, which suggests high type, because meconium calcifies due to urine exposure. We call this study an invertogram. A coin or other metal piece is placed over the expected anus and the baby is turned upside down for a minimum of 3 minutes. The distance of the gas bubble in the rectum from the metal piece is noted. More than 2 cm denotes high type, but less than 2 cm denotes low type. Fluoroscopy is very useful to detect a rectourinary, rectovaginal, or rectoperineal fistula. This image shows a contrast-filled bladder, anus, and urethra. And here we can see a fistula between the anus and the urethra. The treatment and prognosis depends on type anal atresia. Low subtypes are treated with anoplasty, but high subtypes are treated with colostomy with subsequent potential repair. The next topic of this presentation will be necrotizing enterocolitis. Necrotizing enterocolitis is a severe bowel inflammation. The etiology is not entirely clear and seems to be a combination of immature bowel mucosa, infection and ischemia. Inflammation starts from the mucosal surface and progresses to hemorrhagic and coagulative necrosis. There is ensuing loss of mucosal integrity, transmural necrosis and perforation. The most common location is the thermal ileum. Necrotizing enterocolitis usually develops 2 or 3 days following birth, with 90% developing within the first 10 days of life. The incidence is inversely proportional to gestational age, with 90% occurring in premature infants. Its overall incidence is 1 in 1,000 births, but is as high as 20% in low birth weight infants, less than 1,500 grams. Clinical presentation of the disease is not specific to it and includes the following symptoms: pure feeding, bile-stained vomitus, abdominal distension, blood-stained stools plus-minus explosive diarrhea, respiratory distress with acidosis, and sepsis. At this early stage, the radiograph only shows non-specific bowel dilatation. At this stage, you cannot make the diagnosis. The next plain radiograph shows a typical case of necrotizing enterocolitis with pneumatosis intestinalis. We can see lots of mottled lucences or soap bubble lucences. Another complication of necrotizing enterocolitis is portal vein error. Plain radiograph shows us the outline of the liver with lucency evidencing the error in the portal or bile ducts. On the ultrasound image, you can see tiny, hyperechoic points that are error. On the another plain radiograph, we can see pneumoperitoneum and Rigler sigh. Pneumoperitoneum describes gas within the peritoneal cavity, often due to critical illness. There are numerous causes and several mimics. The most common cause of pneumoperitoneum is the disruption of the wall of a hollow viscus. Here we can see lucency, which is pneumoperitoneum, and we can see air on both sides of the bowel wall, Rigler sign. Ultrasound diagnostic may show us bowel wall thickening, alteration of the vascular state, hypervascular, viable button gorge in early stage, or hypovascular, infarcted in a later stage, as well as what is shown in this photo, we can see intramural gas manifesting as hyperechoic foci within the bowel wall. Another sign is free fluid, especially with echogenic debris, suggest perforation. Treatment and prognosis for necrotizing enterocolitis. Stage 1 and 2 receiving medical therapy, and Stage 3 undergoing surgery. Medical management consists of supportive measures and cessation of oral feeding, along with broad-spectrum antibiotics and gastric aspiration. Surgery is usually reserved for patients with evidence of perforation and entails resection of clearly necrotic bowel and the creation of a proximal enterostomy. Despite therapy, mortality remains significant, ranging between 9 and 28%. Furthermore, 20% of surviving patients will go on to develop stricture. These are more common in the large bowel, 80%, and may result in bowel obstruction weeks to months later. Acute appendicitis is an acute inflammation of the vermiformix appendix. It's a very common condition in general radiology practice and is one of the main reasons for abdominal surgery in young patients. Appendicitis may be acute or chronic, but chronic is very rare. Acute appendicitis is typically a disease of children and young adults with a peak incidence in the second to third decades of life. A normal appendix outer diameter is below 6 mm and it's surrounded by homogeneous, non-inflamed fat and often contains intraluminal gas. At sonography, the normal appendix is less frequently visualized, with results varying between 0 to 82%. Extraction is the leading cause of appendicitis, and it can be caused by lymphoid hyperplasia, approximately 60%, appendicolite, approximately 33%, foreign bodies, approximately 4%, Crohn's disease or other rare causes like stricture, tumor, parasite. Obstruction of the appendiceal lumen lead to buildup of fluid, suppurative inflammation, secondary infection, venous congestion, ischemia, and necrosis. Acute appendicitis in ultrasound. This image shows us a 90-year-old woman with appendicitis. Longitudinal and transverse sonogram show a peristaltic, non-compressible, and large appendix arrows surrounded by hyperechoic, inflamed fat arrowheads. Another example of ultrasound acute appendicitis, power Doppler sonography shows hypervascularity of the appendiceal wall. Mural hyperemia with color flow Doppler increases the specificity, but vascular flow may be lost with necrotic stages. Here is another example of acute appendicitis in ultrasound. You can see hyperechoic appendicolic here with posterior acoustic shadowing. Like I said, appendicolic is the second most common causes of obstruction. CT is highly sensitive in acute appendicitis, nearly 94 to 98%, and specific up to 97% for the diagnosis of acute appendicitis. CT findings include appendiceal dilatation more than 6 mm diameter, wall thickening more than 3 mm, and enhancement. Thickening of the cecal apex, cecal bar sign, arrowhead sign. Periappendiceal inflammation, like fat stranding, thickening of the lateral conal fascia or mesoappendix, extraluminal fluid, phlegm, or abscess. Focal wall non-enhancement representing necrosis, gangrenous appendicitis, and is a precursor to perforation. It's a case of 43-year-old man with appendicitis. Contrast-enhanced CT despite the fluid filled, distended appendix with periappendiceal fat stranding. Can compare this fat stranding to the normal fat in the other areas. Here you can see in the right iliac fossa that there is a blinding ending tubular structure, its appendix. Treatment is appendectomy, which can be performed either open or laparoscopically. Mortality from simple appendicitis is approximately 0.1%, but is as high as 5% in perforation with generalized peritonitis. 30% of cases where the appendix has become gangrenous and perforated, initial non-operative management is preferred provided the patient is stable. Recognized complications include perforation in 10 to 20% of cases, most specifically suggested by appendiceal abscess or extraluminal gas, but commonly also seen as periappendiceal phlegm and fluid. Generalized peritonitis due to free perforation, pyephlebitis, infective thrombophlebitis of the portal circulation, or hepatic abscess. The next topic of our presentation will be meconium ileus. Meconium ileus is the neonatal bowel obstruction of the distal ileum due to abnormally thick and impacted meconium. This disease is more common in white populations. Meconium found in the intestine of neonate consists of succus entericus, bile salts, bile acids, and debris from the intestinal mucosa. Meconium is normally evacuated within 6 hours of birth. Approximately 20% of infants with cystic fibrosis present with meconium ileus at birth. Fluoroscopy. Contrast enema will show a microcolon involving the entire large bowel and may show impacted meconium pellets filling defects, particularly in the right colon or in the distal ileum. And you can see here on this image example of fluoroscopy. In this plain radiograph, we can see dilated bowel loops, and classically, in meconium ileus, there is paucity or absence of air fluid levels and bubbly appearance of the distended intestinal loops on radiographs. Treatment, prognosis and complications. Water-soluble contrast enema usually clears the impacted meconium with a success rate of over 60%. We can distinguish following complications like ileal atresia or stenosis, ileal perforation resulting in meconium peritonitis, and volvulus with or without pseudocyst formation. Next presentation will be about Meckel diverticulum. It's a congenital intestinal diverticulum due to fibrous degeneration of the umbilical end of the ophthalmomesenteric duct that occurs around the distal ileum. It is the most common structural congenital anomaly of the gastrointestinal tract. Meckel diverticulum has an equal frequency in both sexes, although symptoms from complications are more common in male patients. The most patients with a complication are thought to present in the first 2 years of life. A large proportion of individuals remains asymptomatic. The incidence of complications with Meckel diverticulum is reported to wide range between 4 and 30% of patients. There is increased incidence of the Meckel diverticulum in Crohn patients compared to the general population. They present gastrointestinal hemorrhage, mostly self-limiting bright red rectal bleed, small bowel obstruction, inflammation, perforation, and neoplasm arising in a Meckel diverticulum. Meckel diverticulum is a true diverticulum. All layers of the gastrointestinal tract are present in its wall and arise from the antimesenteric border of the small intestine. Most, 75% Meckel diverticula, are found within 16 cm of the ileocecal valve. Midline and right iliac fossa location are the commonest. Ultrasound, usually of limited use in the diagnosis of an uncomplicated Meckel diverticulum. Ultrasound may show a blind ending peristaltic loop connected to the small bowel, like here. Computer tomography is also of limited value in uncomplicated cases. CT may show a fluid or air-filled blind ending pouch that arises from the antimesenteric site of the distal ileum. Meckel's diverticulitis. Patients usually present with acute pain in the right lower quadrant. Painless rectal bleeding is also frequent. Meckel diverticulitis is similar in pathogenesis to acute appendicitis or colonic diverticulitis. And like I said, in ultrasound, Meckel diverticula are usually seen as a tubular, incompressible blind ending hypoechoic structure with irregular margin. In computer tomography, we can show mural wall thickening and enhancement with surrounding inflammatory changes in the adjacent fat as well as small reactive mesenteric lymph nodes. Hypertrophic pyloric stenosis will be our next subject of pediatric radiology presentation. Projectile vomiting is the key feature in patients with hypertrophic pyloric stenosis. The cause of the muscle hypertrophy, which causes the gastric outlet obstruction, is unknown. It occurs a familial predisposition and it's more common in boys. Hypertrophic pyloric stenosis typically presents after the neonatal period at the age of 4 to 8 weeks. Start with the basic gastric anatomy and norms. You can see duodenum, pylorus, antrum, greater curvature and lesser curvature. And here we can see normal values of pyloric, length, less than 15 mm, single muscle thickness less than 3 mm, and pyloric width less than 7 mm. When we examine a patient with ultrasound, we do not see passage along the hypertrophic pyloric muscle. Abdominal plain radiograph findings are non-specific, but may show a distended stomach with minimal distal intestinal bowel gas. Caterpillar sign in plain radiograph. The stomach appears distended, air-filled, and with wave-like contours resembling the appearance of caterpillar. The mushroom sign, also called umbrella sign, is a radiological sign described in pyloric stenosis on barium examination. This sign refers to the impression made by the hypertrophic pylorus on the duodenal cup. Treatment and prognosis for hypertrophic pyloric stenosis. Very important is rehydration and correction of electrolyte imbalances. Treatment is surgical with a pyloromyotomy in which the pyloric muscle is divided down to the submucosa. This can be performed both open and laparoscopically. The operation is curative and has very low morbidity. Recurrence is rare and usually due to an incomplete pyloromyotomy. Round pneumonia. This is the type of pneumonia usually only seen in pediatric patients. It is well-defined, rounded opacities that represent regions of infected consolidation. The mean age of patients with round pneumonia is 5 years. It's uncommon after the age of 8 because collateral airways tend to be well developed by this age. Pathology. The adults developed interalveolar communications and collateral airways. These are called pores of Kohn and canals of Lambert. They allow air drift between the parenchymal subsegments. In children where these have not developed, the limited spread of infection results in round pneumonia. There is no specific bacterium that causes round pneumonia, but Streptococcus pneumoniae is the leading cause of round pneumonia. Plain radiograph. Round pneumonias are roundish, and while they are well circumscribed parenchymal opacities, they tend to have irregular margins. They most commonly occur in superior segments of lower lobes, and in the majority of cases, approximately 98%, they are solitary. Air bronchograms are often present, but are only seen in 70% of cases when they occur in adults. The abnormality here is not subtle. There is a large rounded opacity laterally of right heart border. Intussusception. We talk about intussusception when one segment of a bowel is pulled into itself or a neighboring loop of the bowel by peristaltis. The vast majority of intussusceptions, approximately 95%, occur in children, usually after the first 3 months of life. we can distinguish a classic triad of symptoms, which they include intermittent abdominal pain, vomiting, and right upper quadrant mass. These findings, taken together, are seen in less than 20% of intussusception cases. The other symptoms are occult or gross blood on rectal, passing of red stool, current jelly stool, and approximately 15% of cases do not even present with abdominal pain. A proximal part of the bowel is pulled into the distal lumen and propelled forwards as if it were a ball of food. The prolapsing part of the bowel is described as the intussusceptum. The distal segment of a bowel receiving the intussusceptum is described as the isuscipient. As the mesentery is incorporated into the intussusception, venous return is compromised, resulting in edema and further restriction to blood flow. Etiology. In children, a lead point is not identified in 90% of cases, but in infants and adults, a lead point is more frequently identified, with up to 90% of adult cases having a lead point. For example, gastrointestinal malignancy, most common cause in adults, accounting for 65% of cases. It's colorectal carcinoma, the most common. Benign neoplasm, like gastrointestinal stromal tumor, congenital, macrodiverticulum, duplication cyst, or ectopic pancreas. Another example, inflammatory, like periappendicitis, or trauma, like mural hematoma. Location of the intussusception. Ileocolic is most common, 75 to 95%, presumably due to the abundance of a lymphoid tissue related to the terminal ileum and the anatomy of ileocecal region. The next location is ileo-ileocolic, is the second most common. Ileo-ileal and colocolic are uncommon. Gastric intussusception is very rare, but documented. Ultrasound signs include Tardet sign, also known as the donut sign, pseudokidney sign, and crescent in a donut sign. Computer tomography. Best known is the so-called bowel within bowel configuration, in which the layers of the bowel are duplicated, forming concentric rings when imaged at right angles to the lumen, and a soft tissue sausage when imaged longitudinally. Suspected physical abuse in infants and young children represent both ethical and legal challenges to treating physician. Radiologists may be the first clinical staff to suspect non-accidental injuries when confronted with a particular injury pattern. Clinical presentation. Injury in the non-ambulatory, totally dependent child. Injury and history given are inconsistent. Delay in seeking medical attention. Multiple fractures with no family history of osteogenesis imperfecta. Retinal hemorrhage. Torn frenulum. History of household falls resulting in fracture. Despite fall being common, fractures are uncommon. Specific for non-accidental injury are bilateral fractures, with fractures of differing ages, digital fractures in non-ambulant children, vertebral fractures or vertebral subluxation, spiral humeral fractures, separation of epiphyses, complex skull fractures. Metaphyseal fracture, so-called bucket handle fracture or corner fracture, present in up to 39 to 50% of abused infants under 18 months, said to be virtually pathognomonic of non-accidental injury. Ribs fractures, especially posterior ribs fractures. We can see this on display in radiographs. Seen. May have no overlying bruising. Vigorous cardiopulmonary resuscitation can occasionally cause anterior rib fractures. Posterior rib fractures do not occur. Sometimes costochondral junctions, injuries, and fractures. Skull fracture, especially non-parietal skull fracture, because a parietal fracture is more suggestive of accidental injury. Involves multiple bones, diastatic sutures, crosses sutures, depressed fracture. Here we can see some example of plain radiograph. By the right side we can see skull fracture crossing suture in abused child, and by the left side we can see eggshell fracture in a child who died of cerebral injury after being thrown off height. And the other fractures: scapular fractures, sternal fractures, outer third clavicular fractures. Sometimes we can see accidental multiple fractures like on this plain radiograph. It is 1-day-old child with multiple fractures after a problematic delivery. Birth weight was 5,500 grams. We can see clavicular fracture and ribs fracture. The next topic of our presentation will be the supracondylar fracture of the humerus. It's a fracture of the distal end of the humerus just above the elbow joint. The transverse section of the shaft of the humerus is somewhat circular in shape, which gets more flattered as it descends down to meet distal end of the humerus. It's classic pediatric injury. Simple supracondylar fractures are typically in younger children and uncommon in adults. 90% are seen in children younger than 10 years of age, with a peak age of 5 to 7 years. Supracondylar fracture is more commonly in boys. These injuries are almost always due to accidental trauma, such as falling from a moderate height, bunk bed, or monkey bars. Classification of supracondylar fracture. We can distinguish 3 types. Type 1, undisplaced. Type 2, displaced with intact posterior cortex. 2A, no rotational deformity. Type B, rotational deformity. And type 3, complete displacement. Plain radiograph may show us anterior fat pad sign. Sail sign is elevated by a joint effusion and appear as a lucent triangle on the lateral projection. Also, we can see posterior fat pad sign. Anterior humeral line should intersect the middle third of the capitulum in most children, although in children under 4, the anterior humeral line may pass through the anterior third without injury. Here we can see three types of supracondylar fracture. Type 1, we can see undisplaced humerus with anterior and posterior fat pad sign. On the next image, we can see type 2 of supracondylar fracture, and we can see displaced supracondylar fracture with intact posterior cortex. And type 3 with complete displacement. Green stick fracture is an incomplete fractures of long bones and are usually seen in young children. Green stick fracture occur when the force applied to a bone results in bending of the bone such that the structural integrity of the convex surface is overcome. The bending force applied does not break the bone completely. They are commonly mid-diaphyseal, affecting the forearm and lower leg. On the plane radiograph, it occurs in tandem with angulation and with cortical bridge of only one side of the bone. On this plane radiograph, we can see a fracture of the radius and ulna with angulation and with cortical bridge of lateral side of the bones. Torus fractures are incomplete fractures of the shaft of a long bone that's characterized by bulging of the cortex. They result from trabecular compression due to an axial loading force along the long axis of the bone. On the plane radiograph, the distinct fracture lines are not seen. We can only see subtle deformity or buckle of the cortex, but in some cases, angulation is the only diagnostic clue. On these plane radiographs, we can see distal radial metadiaphyseal buccal fracture, which is in here, and proximal humeral metadiaphyseal buccal fracture, which is seen here. The next three issues will be about tumors. We'll start with the Wilms tumor. Wilms tumor are the most common pediatric renal mass, accounting for over 85% of cases and account for 7% of childhood cancers. It typically occurs in early childhood, 1 to 11 years, with peak incidence between 3 and 4 years of age. Approximately 80% of these tumors are found before the age of 5 years. There is no recognized gender predilection, however, presentation is a little later in females. Clinical presentation is typically with a painless upper quadrant abdominal mass. Hematuria is seen approximately 20% of cases, and pain is uncommon. On examination, hypertension due to excessive renin production is found in up to 25% of patients, and acquired von Willebrand disease is seen in 8%. Wilms tumors are usually large, heterogeneous solid masses which display adjacent structures. Occasionally, they may be mostly cystic. Metastases are most commonly to lung, approximately 85%, liver, and local lymph nodes. Similar to renal cell carcinoma, tumor thrombus into the renal vein, IVC, and right atrium is also characteristic of advanced disease. Ultrasound is a very useful examination and in almost every situation will be the primary investigation of choice. It's helpful to localize the mass to the kidney and also distinguish from other causes of renal masses, example
hydronephrosis. Although many of features seen on CT or MRI can also be identified on ultrasound, the former are required to adequately stage the disease and is established in protocols for Wilms tumor staging in North America and Europe. Doppler examination can be performed to examine the renal vein and IVC to assess for the presence of tumor thrombus. In the first picture, we can see a vascular hyperechogenic lesion with wall in the left kidney. Doppler examination shows vessels running circumferentially in relation to the mass. The last image shows us hyperechoic points that are calcifications. Computer tomography. Wilms tumors are heterogeneous, soft tissue density masses with infrequent areas of calcifications, approximately 50% at fat density regions. Enhancement is also patchy and allows for better delineation of the relationship between the mass and kidney. 10 to 20% of cases have lung metastasis at the time of diagnosis. Computer tomography without or with an contrast shows huge solid mass in right kidney. Unilateral Wilms tumors are usually treated by a combination of nephrectomy and chemotherapy. Occasionally, chemotherapy can be administered prior to surgery to downstage the tumor. This is especially useful when the tumors are bilateral. Radiotherapy has a limited role but may be employed in cases of peritoneal spread or incomplete resection. Cure is now possible in approximately 90% of cases. Recurrence is seen both within the tumor bed as well as distally within the lungs or liver.
The next issue for tumors will be neuroblastoma. Neuroblastomas are tumors of neuroblastic origin, although they may occur anywhere along the sympathetic chain. A vast majority arise from the adrenal gland, 35 to 50%, but can also develop in the neck, chest, abdomen or spine. They represent the most common extracranial solid childhood malignancy and are the third commonest childhood tumor after leukemia and brain malignancies. They are the most common intra-abdominal tumors, approximately 30%, and the most common cancer in babies. The tumors typically occur in infants and very young children, mean age of presentation being 25 months, with 90% of cases diagnosed before the age of 10 years. Occasionally, they may be identified antenatally or immediately at birth. They account for approximately 50% of childhood cancer deaths. What can be said about the clinical symptoms? The neuroblastoma present typically with the pain or a palpable mass and abdominal distension. The consequences encountered due to local mass effect. The other accompanying syndromes include skeletal metastasis may present with skeletal pain or limping and irritability or proptosis with periorbital and cranial bumps. What is known as Hutchinson syndrome? Pepper syndrome, it is a hepatomegaly due to extensive liver metastasis. Blueberry muffin syndrome, which is multiple cutaneous lesions.
Opsomyoclonus, its rapid, involuntary, conjugate, fast eye movements. Proptosis and periorbital ecchymos, raccoonitis, which is caused by orbital metastasis. In the ultrasound imagination, the neuroblastoma demonstrates as a heterogeneous mass with internal vascularity. Often, there are areas of necrosis that appear as regions of low echogenicity. Calcification may or may not be evident on ultrasound. This image shows a neuroblastoma in a 1-year-old boy who presented with vomiting. The tumor encircles the aorta, which is lifted from the vertebral column, and also small calcifications are present. On computer tomography, the tumor typically is heterogeneous with calcifications seen in 80 to 90% of cases. Areas of necrosis are of low attenuation. The tumor morphology is often helpful, with the mass seen insinuating itself beneath the aorta and lifting it off the vertebral column. It tends to encase vessels and may lead to compression. Adjacent organs are usually displaced, although in more aggressive tumors, direct invasion of the psoas muscles or kidney can be seen. The latter can make distinguish neuroblastoma from Wilms tumor difficult. Both in CT and ultrasound, the lymph node enlargement is often present. Treatment and prognosis depends on the patient's stage. There are two methods of neuroblastoma staging. One that is based on post-operative patients, and one developed for pre-treatment patients. Localized tumors, considered to be low risk, are surgically excised, and the patients tend to do very well. In high-risk tumors, combination of surgery, chemotherapy, plus or minus bone marrow transplantation is employed, unfortunately with poor overall results. In some cases, where tumors are very large, presurgical chemotherapy to attempt to downstage the tumor may be administered. Patients with stage 1, 2, or 4S have a better prognosis. Unfortunately, 30 to 60% of patients present with stage 3 or 4 disease. For advanced disease, the age of the child is the most important. The MRI findings are mass with an encasement of the aorta, extension along the thoracic vertebral columns but not intraspinal invasion. Also, we can see a small liver metastasis and left supraclavicular mass. Ewing sarcomas are the second most common malignant primary bone tumors of childhood after osteosarcoma, typically arising from the medullary cavity with the invasion of the Haversian system. Ewing sarcoma typically occurs in children and adolescents between 10 and 20 years of age and has slight male predilection. The Ewing sarcoma family of tumors primarily occurs in white patients. Based on the age, the location, and the radiographic appearance, the diagnosis of Ewing sarcoma can be made in over 70% of cases. In long bones, the tumor is most commonly located centrally in the meta or diaphysis, and we can see some favored location, like lower limb
approximately 45%, and the femur is most common, pelvis approximately 20%, spine and ribs approximately 30%, and the sacrococcygeal region is the most common. Ewing sarcomas usually present as mouth-eaten, destructive and permeative loosened lesions in the shaft of long bones, with a large soft tissue component and typical onion-skinned periostitis. These tumors may also involve flat bones and can appear sclerotic in up to 30% of cases. They occasionally demonstrate other appearance, including Codman triangles, spiculated or thick periosteal reaction, and even bow expansion or cystic components. Soft tissue calcification is uncommon, seen in less than 10% of cases. Here we have an example of permeative. Permeative describes multiple small endostyle loosened lesions or holes, often with poorly defined margins, with sparring of the cortex, and it is seen in 67% of cases. It's a bone marrow process. On this plain radiograph, we can see lamellated periosteal reaction, which is called onion skin. It demonstrates multiple concentric parallel layers of new bone adjacent to the cortex, reminiscent of the layers on an onion. In the next plain radiograph, we can see a Codman triangle. The periosteum does not have time to ossify with shells of new bone in an aggressive lesions, so only the edge of the raised periosteum will ossify. On this frontal and lateral plane radiograph, we can see a destructive soft tissue mass in the middle phalanx of the right hand, which shows near total destruction. Its remnants show expansion and mark osteolytic changes, this also involving the distal half of the proximal phalanx, showing mild expansion, osteolysis with prominent trabecula. Treatment and prognosis. Systemic chemotherapy is the mainstay of treatment, with surgery and radiotherapy playing a role depending on the location and size of the tumor. Spinal tumors have up to 86% long-term survival compared to 25% of sacrococcygeal tumors. Prognosis is significantly impacted by the presence of distant metastases at the time of diagnosis. Metastases most frequently go to the lungs and bones in equal proportions. The spine is the most common site of bone metastasis. Now, we will talk about testicular torsion. Testicular torsion occurs when a testis torts on the spermatic cord, resulting in the cutting of a blood supply. The most common symptom is acute testicular pain, and the most common underlying cause, a bell clapper deformity. The diagnosis is made on the basis of these symptoms, but if you have any doubts, you can do an ultrasound. Differentiation between testicular torsion and epididyma orchitis is a clinical challenge, since scrotal pain, swelling, and redness or tenderness are clinical symptoms common to these two entities. A bell clapper deformity is a predisposing factor in testicular torsion in which the tunica vaginalis has an abnormally high attachment to the spermatic cord, leaving the testis free to rotate. Bell clapper deformity predisposes to intravaginal torsion of the testis. The majority of cases of testicular torsion are either spontaneous or in the settings of minor incidental trauma. In approximately 5 to 8% of cases, scrotal trauma is significant. The hemiscrotum may be swollen or erythematous. The onset of severe testicular pain is sudden, and it's not relieved by elevation of the scrotum. There should be no fever or urethral discharge. It is important to recognize that some patients may present with intermittent symptoms due to spontaneous detorsion, so-called intermittent testicular torsion. Short periods of acute growing pain accompanied by vomiting and subsequent spontaneous relief. Physical examination may reveal elevation of the affected testis, an abscess of the cremasteric reflex, transverse lie of the testis, anterior rotation of epididymis, and pain relief with successful manual detorsion. Ultrasound key findings of torsed testis include: the Whirlpool sign refers to a lamellated mass with concentric layering just cephalad to the testis, representing the cold spermatic cord components. Altered blood flow, complete torsion, and absence of blood flow in both the testis and epididymis. Increase in the size of the testis and epididymis. Homogeneous echo texture is an early finding before necrosis, but heterogeneous echo texture is a late finding after 24 hours, implies necrosis, and in ultrasound, hypoechoic regions represent necrosis, but hyperechogenic regions represent hemorrhage. And the other key findings is reactive hydrocele and reactive thickening of the scrotal skin with hyperemia and increased flow on color Doppler examination. Also, we can see peripheral testicular neovascularization. It's only seen after a number of days and represents recruiting and enlargement of small peripheral collaterals. Some examples of ultrasound. In the left image, we can see a relative enlargement and hypoechogenicity of the right testicle relative to the left. No flow on color Doppler imaging. Findings are compatible with testicular torsion. On the right image, ultrasound demonstrates an enlarged, hypoechoic left testis with no internal vascularity. There is a complex left hydrocele, normal look testis, and a simple hydrocele on the right. The last part of our lecture will be about vesicoureteric reflux. Vesicoureteric reflux is the term for the abnormal flow of urine from the bladder into the upper urinary tract, and it's typically encountered in young children. Among children with urinary tract infections, the incidence of vesicoureteric reflux rises to approximately 25 to 40%. Reflux from the bladder into the upper urinary tract predisposed to pyelonephritis by allowing entry of bacteria to the usually sterile upper tract. As such, the diagnosis is first suspected after urinary tract infection in a young child. This slide shows us grading of vesicoureteric reflux. Grade 1. Reflux limited to the ureter. Grade 2. Reflux up to the renal pelvis. Grade 3. Mild dilatation of ureter and pelvic calcial system. Grade 4. Tortuous ureter with moderate dilatation, blunting of fornices, but preserved papillary impressions. And Grade 5. Tortuous ureter with severe dilatation of ureter and pelvic calcial system, loss of fornices and papillary impressions. Voiding cystourethrogram is the primary diagnostic procedure for evaluation of vesicoureteric reflux. which however requires bladder catheterization and distension of the bladder. Voiding cystourethrogram should be performed after the first well-documented urinary tract infection up to the age of 6 years. Now we can see voiding cystourethrogram grade 3, which demonstrates reflux into left kidney with mild dilatation of the left ureter and renal collecting system. The calyx are slightly distended and blunted. Grade 4. Prevoid contrast-filled bladder demonstrate bilateral vesicourethral reflux with mildly tortuous and moderately dilated ureters, with contrast-reaching blunted dilated calyx. Low pressure vesicourethral reflux. After voiding, the collecting system fill even further, compatible with a component of high-pressure vesicourethral reflux. Findings are keeping with bilateral type 4 vesicourethral reflux. And grade 5. Voiding cystourethrogram demonstrate reflux into both kidneys with dilatation of the ureters and renal collecting system. The calyx are distended and blunted. Treatment and prognosis. Significant vesicourethral reflux, if untreated, may lead to recurrent urinary tract infections, renal scarring, and eventually renal failure, reflux nephropathy. Low-grade reflux may be treated by prophylactic antibiotic treatment. Surgical reimplantation for the treatment of higher grades of reflux is aimed at reducing the incidence of reflux nephropathy. Endoscopic treatment, performed by injection of a bulking agent at the uretrovesical junction, may be used and is variably effective in preventing sequelae of reflux. This will be the end of our lecture. Thank you for watching.